Congenital Heart Defects by Elizabeth, Becca, and Reagan.
Normal physiology and anatomy of the heart. In a normally functioning heart, oxygen-poor blood is carried into the right atrium superiorly and inferiorly by the superior vena cava and the inferior vena cava. As blood fills in the cavity, pressure builds and forces the tricuspid valve open. Blood then flows into the right ventricle, the ventricle contracts, and the tricuspid valve closes to stop backflow. The oxygen-poor blood is then forced through the pulmonary semilunar valve into the pulmonary trunk, where it then travels to the lungs for gas exchange. The now oxygen-rich blood enters the left atrium via the pulmonary veins. This build of pressure forces the mitral valve open and blood flows into the left ventricle. From here, the aortic semilunar valve opens and blood exits into the aorta, where it is distributed superiorly and inferiorly through the systemic circuit. The arteries of the heart carry blood away from it and are elastic and can stretch under pressure. These elastic arteries are primarily smooth muscle and elastic tissue. The atria of the heart have relatively small and smooth walls because they do not normally require to exert a large amount of force. The ventricles have thicker, more muscular walls compared to the atria because they propel blood a further distance to the lungs and throughout the rest of the body. Separating the atria and the ventricles are the interatrial and interventricular septums. The interventricular septum, in particular, contracts with the ventricles to assist in blood propulsion. The heart's basic rhythm is set by autonomic parasympathetic and sympathetic nerve fibers, even though it does not require innervation to depolarize and contract. The sinoatrial node sets the pace, and this travels to the atrioventricular node, where a delay of 0.1 seconds allows the atria to fully contract before the ventricles do. Following, an atrioventricular bundle in the interventricular septum divides into right and left branches that form the subendocardial conducting network, which is responsible for heart contractions. Because the heart requires enough force to contract and pump blood throughout the entire circulatory system, its cardiac muscle cells and the mitochondria within them demand more oxygen than regular skeletal muscle cells. Aerobic respiration is a process used by cardiac muscle cells to use oxygen to convert fatty acids and carbohydrates into ATP, the body's energy or fuel. Unlike skeletal muscle cells, cardiac cells cannot use anaerobic respiration when there is an insufficient amount of oxygen. In comparison, anaerobic respiration breaks down glucose into ATP and pyruvic acid without the use of oxygen. This is why sending deoxygenated blood into the respiratory system is so important. It ensures that hemoglobin in the blood can bind to new oxygen we inhale, and so carbon dioxide can be unloaded into the air we exhale. This process is known as external respiration and occurs by diffusion between capillaries and the alveoli in the lungs. The deoxygenated blood received by the right side of the heart is a result of internal respiration, where oxygen diffuses into the body tissues and carbon dioxide moves out into the surrounding capillaries.
Abnormal physiology and homeostatic imbalance. A ventricular septal defect is one of many types of congenital heart defects, but it is the most common. VSD is a result of the malformation of the ventricular septum, which is the wall that separates the two ventricular cavities. This malformation occurs in utero when the heart is developing. Muscular tissues grow upwards from the apex of the heart. This tissue is supposed to connect to the membranous tissue that's growing downwards from an endocardial cushion. In around 80% of VSD cases, it was the membranous tissue that caused the malformation. Causes. The cause of this congenital heart defect is not officially known yet, but there is evidence that alcohol, smoking, and certain medications can play a part. Premature birth, the mother's health and environment, as well as mutated genes or chromosomes, are also believed to play a part in the birth defect. What causes what? Because of the missing tissue separating the ventricles, blood can flow between the two chambers. It is more likely to flow from left to right because the left side of the heart is stronger and has a higher contractility. Shunt is a term for when blood abnormally moves from one area to another. A VSD would be considered a cardiac shunt. More blood than normal is entering the right ventricle, and therefore the lungs. Because of the excess fluid coming in, pulmonary arterial hypertension develops. This can lead to the arteries and even capillaries dilating to accommodate the new volume. If the capillaries are stretched enough, they can start to leak fluid into the lungs, causing respiratory issues and pulmonary edema. Because the pressure has been raised in the lungs, it's now harder for the right side of the heart to pump blood through. This results in hypertrophy, which is an increase in the thickness of the muscle, in this case, the ventricular wall. This can eventually cause cardiomegaly, which is an enlarged heart. There could be less ejected blood coming from the right ventricle until it builds up enough strength and pressure to get past the pulmonary valve. Eisenmenger syndrome develops as a result of the irregular blood flow and hypertension. When the right ventricle grows enough to overpower the pulmonary pressure, it also flips the direction of blood flow through the hole, causing a shunt inversion. Now, the blood flows from the right to the left ventricle, meaning that oxygen-poor blood is being pumped throughout the body. This can cause cyanosis, which is when the fingertips or lips turn blue due to a lack of oxygen in the blood. Symptoms and causes. Two of the main symptoms of VSD are shortness of breath and fatigue, which are caused by fluid in the lungs that limits the exchange of oxygen and carbon dioxide because the fluid increases the effective thickness of the alveolar wall and decreases the area of gas exchange. It is more often a lack of oxygen in the blood that is the issue rather than too much carbon dioxide, because CO2 is able to pass through the fluid easier to exchange in the alveolar membrane. A lack of oxygen in the blood is called hypoxemia. Some other common symptoms are difficulty feeding due to fatigue, as well as failure to thrive, which can happen for multiple reasons, one of which is inadequate nutrition from the difficulty feeding. And lastly, heart failure, which is a result of the heart being overworked. The aerobic respiration in the heart affects the ion pumps that play a role in the resting action potential and heart contraction. Three main factors influence the amount of oxygen needed, those being heart rate, contractility, and ventricular tension. When one of these three factors increases, for example, how the ventricular wall tension increases in VSD patients, the heart requires more oxygen. But to get more oxygen, the heart must work harder, and eventually the cycle leads to heart failure.
Treatment options and current research. The treatment options. There are two main ways of treating a congenital heart defect. When the defect is severe, surgery is used to repair the damaged areas of the heart. In cases that are less severe, cardiac catheterization can be used. In this procedure, a catheter is put into the blood vessels to allow the doctor to test, measure, and then repair the problem to the best of their ability. In some cases, they are not able to fully repair the heart because there is too much damage. It is also important to note that in many cases the treatment may not be completely effective and the heart may not be fully fixed. These procedures do allow for better blood flow through the heart, but the functionality of the heart may never be at its full capacity. And in some cases, there is no treatment possible because the defect is not large enough to fix. Study 1. This study was developed to see how Canada would be able to improve the follow-up practices for children that have gone through congenital heart defect surgery. During the study, they sent out questionnaires to the 8 hospitals that performed the surgery to find out what they thought the best follow-up procedures would be. The study found that 4 of the 8 hospitals have follow-up programs that include both screening and an evaluation, but this is only available for children with higher risk congenital heart defects. The research team concluded that the follow-up practices in Canada are not optimal, and the follow-up procedures do not identify congenital heart defect children that have had developmental challenges. The research team believes that it is necessary to improve the follow-up procedures across Canada. Study 2. The researchers in this study are looking to abnormal placentation on congenital heart defects to see if this may be a cause, because the causes for congenital heart defects are mostly unknown. The flow of blood through the heart was studied, and this shows that there is a possibility that placental dysfunction may be a contributing factor to congenital heart defects. They also looked into whether the disruption of developmental pathways contributes to the placental dysfunction, but both of these are not fully known yet, and further research has to be done. Study 3. This study looked into the effects of alcohol and drugs in regards to the development of congenital heart defects. They found that women who excessively drank more than one time in the 3 months before their pregnancy, compared to women who did not do this, had an increase in congenital cardiac defects, around 95%. They also found that the chances of a congenital heart defect occurring increases even more when the woman is both smoking and drinking prior to pregnancy. References.